Hello, my name is Dr. Lukejohn, Assistant Professor of Clinical Medicine at the San Francisco General Hospital.
And my name is Dr. Justin Sewell. I'm Assistant Clinical Professor of Medicine, also at San Francisco General Hospital.
Today, we're going to be talking about our upcoming paper that will be published in GIE entitled Assessment of Delivery Methods of the Informed Consent Process at a California Safety Net Hospital. Informed consent is both ethically and legally required before patients undergo an endoscopic procedure. However, literature on this topic is quite scarce, and of the available literature, patient comprehension and understanding of the informed consent process is poor. In order to address this gap within the literature, we sought to examine patients' recall of all elements of the informed consent process, as well as their reported satisfaction with it, in a large, diverse patient setting at a county hospital in San Francisco, California.
We conducted a prospective cross-sectional survey of 356 patients referred to the San Francisco General Hospital and Trauma Center Gastroenterology Division for an outpatient endoscopic procedure. Our survey assessed whether specific components of informed consent were explained, self-reported understanding of the informed consent process, and patient satisfaction with the informed consent process. We compared patients who were consented in a multilingual endoscopy education class taught by an endoscopist with patients who were consented by providers during an ambulatory appointment in the GI clinic.
There were a number of interesting findings from our study. First, the majority of patients in our study reported that most elements of the informed consent process were explained to them. Second, there was a very high patient satisfaction with the informed consent process within our study. In fact, nearly 78% of patients reported that the information given to them was just right. However, there were several elements of the informed consent process that were not explained to patients. In nearly 1/3 of patients, the alternatives to the procedure were not explained to them. Additionally, in 1/5 of patients, either the risk of the procedure or what to expect after the procedure were not explained to them. Additionally, in another 1/5 of patients, they recalled that they were not given an opportunity to refuse the procedure.
In multivariate analysis, compared with patients who were consented in the GI clinic, patients who attended an education class were more likely to recall having had the alternatives, details of the procedure, and what to expect after their procedure explained to them by a provider. They were also more likely to know that they could refuse the procedure.
The findings from our study shed important light on new information that could be useful to gastroenterologists in their daily practice. Such information can be used to develop quality and educational improvement projects for not only gastroenterologists, but GI trainees as well. One question that arisen from our study is, what is the best method to use in delivering informed consent to patients undergoing an endoscopic procedure? The literature on this topic is sparse, and some studies have suggested interventions such as multimedia, audiovisual, extended written instructions, extended discussions, as well as test feedback mechanisms may all be useful in improving the informed consent process. Our multilingual education class has many benefits over these other interventions. Our education class is straightforward, patient-centered, does not require costly infrastructure or new equipment, and does not require patients to have a computer or access to the internet. The group nature of our education class also has many benefits as well. Patients' questions and answers are answered within a group setting, which can be shared by the entire group, thereby helping to enforce and enhance the informed consent process. Such a patient-centered, efficient, and cost-effective method can be applied in any clinical setting and may be of particular benefit in settings with a diverse patient population such as ours.
Thus, in our study, patients from a diverse urban population who attended a multilingual endoscopy education class recalled having more elements of the informed consent process explained to them, compared with patients who were counseled and consented in the usual manner in the GI clinic. Furthermore, patient satisfaction with the informed consent process was similar between patients who attended the class or the GI clinic. Education classes can play an important and critical role in the education of patients prior to their endoscopic procedure and can be an effective tool for ensuring that patients are properly and adequately informed about their procedure.